Good morning, good afternoon, or good evening, wherever you may be. My name is Mary Napolitano, and I'm one of the product managers for Adaptivo, and I work for Standard Imaging. We will be recording this webinar, and so if you are pulled away or if you have some internet connectivity issues, we will be sending out links to the recording either this afternoon or tomorrow. Everyone on the call will remain on mute, but if you have questions, please feel free to enter those into the question box, and we will address those at the end of the presentation. So please feel free at any time to go ahead and enter your questions, so they'll be there at the end. And at this time, I would like to go ahead and introduce Stephanie Key. She has been working on the Adaptivo project for the past 5 years. She has worked as the Director of Clinical Application Development for 21st Century Oncology, and she has consulted with us here at Standard Imaging to make Adaptivo a better product. And so with no further ado, I would like to turn the mic over to Stephanie.
Hello, everyone. So again, as Mary said, my name is Stephanie Key, and I'm here today to present to you the Adaptivo dosimetry software, which most of the information you're going to see here was gained using the software clinically within the 21st Century Oncology Network. I'm going to start by just reviewing the typical radiotherapy workflow. So we start with our prescription and simulation. And once the physician has provided a prescription, simulation is performed. The patient is placed into the setup position and images are acquired, which will be used for treatment planning purposes. A treatment plan is generated and approved by the physician, at which point QA takes place. When the physicist approves the QA, it's time for the patient to start treatment. So for most cases, we're going to be performing daily imaging for patient setup and anatomy evaluation. Once the patient is in the best position for treatment, treatment delivery is performed. So what we'd like to do is use the information acquired at the time of treatment, so cone beam CT, and then the data acquired during treatment delivery, and use that information to assess patient treatment and then make informed decisions on whether or not to maintain a current course, adjust a course of treatment, or adapt a course of treatment, taking us back to simulation and treatment planning. And that's where Adaptivo comes into play. So there are 3 major components to the Adaptivo software. There's the pretreatment QA portion, the in vivo portion, which uses the information acquired at the time of treatment to perform treatment evaluation, and then the adaptive portion, which uses the cone beam CT to recalculate dose and assess dose changes that could be occurring over time. So in the pretreatment QA module, what we're doing is we're using the portal imager to verify plan delivery. The data measured on the portal imager is compared to a predicted image, and that predicted image is based on the treatment planning information. And then gamma is used to assess whether or not the measured signal matches the predicted signal from treatment planning. That gamma analysis is available to the user for review. It's signed gamma, indicating that measured signal is higher or lower than what the treatment plan should indicate that beam should measure. And then profiles are available to the user as well to verify whether or not a good match exists across the field. Notification of results is automatic and available within the software for the user to review. In the in vivo module, we're also using the portal imager. And what happens is, while the patient is being treated, an exit image is acquired. And we use the CU values to evaluate whether or not the measured portal image matches a predicted portal image. We're monitoring beam delivery and patient position. And again, that predicted exit image is based on the treatment plan information. So we're predicting what the image should be, and then comparing that prediction to what's measured for each being for each fraction. Signed gamma analysis is used for review, and then if a deviation occurs based on the gamma criterion that's configured in the software, that would be notified to the user automatically. Reports can be generated, and those reports can either be inserted into the patient chart. They can also be sent to the physician for review and discussion. And then last, we have the adaptive module. The adaptive module uses the cone beam CT. And with that cone beam CT, we're calculating dose daily, and then using deformable registration to create a cumulative dose that can be used to assess patient changes over time. This is fully automated. Once the plan is configured in the software for adaptive analysis, each fraction is retrieved and calculated so that results are ready to review in a timely manner. There's dose that can be reviewed in the software. Again, daily dose as well as cumulative dose. And then DVH information is also provided to the user for analysis. We have templates configured based on Quantec and RTOG protocols, which will notify the user if a dose deviation occurs. These are configurable, and new rules can be added or existing rules can be modified based on your current clinical protocols. When deviations occur, those are notified to the user automatically, and results can be reviewed within the software. So at this point, I'm going to go ahead and provide a demonstration of the software live so that you can see what it looks like to review the tool itself. Sorry. Okay, here we go. So this is the adaptive software dashboard. So I'm logged in as a user. This is a web-based tool, so any computer within a hospital or clinic network can access the server. You can kind of work from the active alerts menu. So any active alerts that are existing in the software are displayed to the user here in the active alerts area, so you know which patients require review. Each plan is displayed in a row. So you have the patient identifying information, the plan information, the last delivered date and timestamp, and then each one of these little boxes indicates a planned fraction. When there's a color fill, it indicates whether or not the gamma calculation was within tolerance. So green would indicate that the gamma criteria was met for this fraction. Yellow indicates that the results are in the warning region, and red indicates that the results are outside of the tolerances that are configured in the software. When you review in vivo results, so again, we have three different components here. So we're looking at in vivo results, which are these green, yellow, and red chiclets, or little fraction boxes. The adaptive notifications are displayed by ROI, and then you have indications whether or not a deviation occurs. These are color-coded as well. So a blue is a rule that's been broken at the plan level. So a nice feature in the software is that you can configure plan rules. So if a treatment plan is imported into the software with an ROI that is outside of the tolerances configured in the software, it will notify you immediately. So for this particular ROI, the rectum, the rule is that 60% of the volume should receive less than or equal to 40 gray. The rule is broken very slightly in that the actual value of the rectum is the D60% is at 40.93 gray. So the user can assess this, discuss with the physician. The physician may be well aware it could have been something that slid through the cracks. There are quite a few ROIs in many plans these days, so it's just a nice quick QA tool to verify that the planning criteria are met for each plan. The orange badge indicates a cumulative rule has been broken. So we have for the rectum, the ROI rectum, that the rule is set again at D60 should be less than or equal to 40 gray. But in this particular instance, over 28 fractions, the D60% is actually at 43.9 gray. This could be well within the clinical limits for this particular disease site. But in the event that you would like to minimize dose to the rectum, you have this information available to you. And then the QA results are displayed here at the bottom of the dashboard. So it's pretty clear. In the dashboard view, you have access to all 3 levels of results. To review a plan, you do so by clicking the plan link or clicking a fraction itself. And what you see initially is a matrix of images. So each column indicates a fraction, and each row indicates a beam that's been planned for this particular treatment delivery. The image you see here is the fluence image. So we have our DRR with sine gamma displayed on the DRR. So areas in red indicate areas that are higher, the measured dose is higher than the predicted signal. And the areas in blue indicate regions that are lower than the predicted signal. So for fraction 1, we're actually outside of the tolerance of the gamma criteria configured in the software for the medial and lateral tangents, but all the subsequent fractions are passing within limits. To review or assess a beam, you click on the color bar. So this is the gamma result. It's passing at 78.2%. You view beam details, and again, you have some information available for assessment. You have the gamma results as well as profile information that can be reviewed. You have your portal dose over and plan fluence information that can be reviewed. And then you have a straight gamma comparison. So you can see the gamma results in the areas that are higher than 1 and the areas that are within 0.5 and 1. Sine gamma is very useful though, because when I see this, I say immediately something's happening with the position, because the area just at the skin surface is high and the area at the lung, the edge of the field, the lateral edge of the field is cold. So indicating to me that we have some sort of positioning issue on fraction 1. And you can see those results in the profiles here. The area along the field in the x-axis is slightly higher. So green dashed indicates the measured portal. Red indicates the predicted image and the predicted signal. To navigate back, you just simply go to the dashboard again. To review adaptive results, the same thing. Clicking the plan link, we go to the adaptive tab. We don't have any in vivo calculation results for this particular plan, but we do have the dose calculated on the cone beam CT. So immediately you see 2 different DVH charts. You see your daily DVH. The solid line indicates our planned DVH. The dashed line indicates the dose calculated on the daily cone beam CT. We use deformable registration to generate the ROIs. So the planned contours are deformed to the cone beam CT, and then dose is calculated on the cone beam CT, and the DVH results are based on those deformed contours. That dose is mapped back to the planning CT for accumulation. So the cumulative DVH you see here, again, the solid line indicates the planned dose to a particular ROI, and the dashed line indicates the cumulative dose up to the last calculated fraction. So when you see deviations occur, you have the ability to review those doses. But again, this dose is based on dose mapped back to the planning CT using a deformable registration algorithm. You can review dose in the patient. We have 4 different views here. So you have your ROIs indicated and displayed here. The first box is our registered cone beam CT to planning CT. So I can scroll through each fraction. The fractions are indicated here. So we're looking at fraction 4. You can kind of tell how the patient's setting up. The image here shows us the dose calculated on the cone beam CT with deformed contours. We have our planning dose here for reference to indicate whether or not you see a change in the planned dose compared to the delivered or recalculated dose. And then this dose gets mapped back to the planning CT for dose accumulation. The other viewer that we have, so again, we still see our merge CT, and you can look at each fraction for a specific plan. You can look at the transverse, the coronal, or the sagittal orientation. And what we have here is a dose difference image. And this is really useful because it shows us the regions of the patient where the dose calculated or the cumulative dose differs from the planning dose. Areas in red indicate areas that are higher than expected. Areas in blue and green indicate regions of the patient where dose is lower than expected. Again, we have our deformed dose here for review compared to the planning dose. So you see that the region of 56.7 gray is slightly higher in this patient than what was planned. Again, as for the in vivo results, we have the deviations or the dose deviations that occur displayed to the user. As I mentioned in the dashboard, we have the QA of the plan, we have the cumulative rules, and then we have daily rules. You can evaluate each individual region of interest. So for this particular parotid, the left parotid, we have a plan deviation as well as a cumulative deviation. The D mean for the left parotid should have had a rule of 25 gray. It was planned slightly higher, so the D mean was at almost 30 gray in this particular instance, but that was okay with the physician. The cumulative dose, though, is the area that we're more concerned about, because as the patients lost weight over the course of treatment, the D mean is now at 40 gray, where we were trying to keep it around 30 gray, so it's 10 gray higher than expected. And all of this is available to the user for review. You can view trending data for an individual ROI, so we can kind of see the volume of the parotid trend down over time. We can see the cumulative dose of the parotid trend up over time. This is available to the user also as additional information or data points. So that's the software at a very high level. We're going to go back to the presentation at this point, and I'd like to show you, so you have this information available, so how are you going to use this in the clinic to improve your clinical practice? So the most common causes of dose differences that we've observed are incidental error, meaning that something is a one-time occurrence that could be based on patient position or something that changed in the delivery for that particular day. And then there's systematic error that occurs that are most commonly related to either inconsistent patient positioning or anatomical changes. So in the case of many head and neck, you see weight loss that occurs over time. But there can also be anatomical changes that occur when you have inconsistent sim to treatment. So you're treating with a full bladder, but then you're simming with a full bladder, but then the patient is treated with an empty bladder or a partially full bladder. So these are what we're referring to as more systematic type of errors. And then there's potential practice improvement, where you can evaluate differences in plans to determine whether or not there are some plans that just tend to be more robust than others, meaning that there's less difference seen when small changes occur in patient setup or anatomy. And then simulations. So are we simming our patients so that each setup is reproducible? You can start to make correlations between immobilization devices and patient setup or arm position in breast cases. It can also help you identify cases that may need breath control techniques, things like that. So the following slides are going to contain case studies from situations in 21C that I thought were interesting and wanted to share. So the first one is an example of an incidental error. So we're treating a left lung tumor. And like I mentioned in the software demonstration, the green area indicates the daily setup, and the red indicates the planned setup. So you see pretty clearly there's a misalignment on fraction. This is actually fraction 18, just for information purposes. But you can see there's a misalignment in this fraction. When we look at the dose that was calculated and adapted, this is our planned dose. So the PTV coverage is quite homogeneous, and we see a full PTV coverage here. But when we look at fraction 18, there's a significant underdose. We're missing this portion of the PTV due to the alignment issue that we can observe here. Why was this missed on the machine? Probably they were aligning the bony anatomy or vertebral bodies. It just wasn't caught on the machine, but it was caught in the software. And we can kind of see the extent of that miss recalculated in adaptive. Looking at the DVH data, we have our cumulative DVH. So this is the whole plan DVH. This is cumulative dose. So overall, the misalignment on one fraction did not have a significant impact on the cumulative dose to the patient. And when you look at the daily DVH, we can see, wow, there is a significant difference between delivered and planned. But the physician has this information available to them so that they can make determinations on how to proceed. So what we have for this particular case, and to kind of summarize, is that the in vivo provides an alert to the difference in delivery. So you see that the measured image does not match the predicted image. When we have adaptive, we can recalculate that dose to understand the dosimetric effect of that misalignment to determine is correction necessary. The ability to review the calculated dose gives the physician confidence to determine whether or not they want to correct, or if they feel like that the dose is going to be sufficient for this particular PTV. A hugely valuable component is staff training, because you can take this information to the staff and quantify to them, this is what's occurring when we have these misalignments. Make sure you're looking at X, Y, and Z, because when the images aren't registered properly, we have an underdose of the PTV. So staff training is a really important component to this. The second clinical example is an example of systematic error. So the most common type of systematic error occurs in head and neck cases, typically because they lose weight. In this specific instance, we had a mask that was poorly made, and which impacted setup. But the effects of all of this can be tracked in Adaptive. Again, we looked at this when we were reviewing the software, but this is our dose difference image. So the areas in red, pink, and yellow indicate regions of the patient that are receiving a higher dose than planned, and blue and green indicate regions of the patient that are receiving a lower dose than planned. Alerts on the dashboard are generated and communicated to the user to review specific regions of interest. And then DVH data can be evaluated to determine the extent of that dose difference. So we've got our right and left carotids that are both receiving higher than planned dose. The left carotid is a more significant difference than right, but the plan was to be that 50% of the carotid, left carotid, would have been around 25 gray, where at this point we're at around 35 gray, so 10 gray higher than planned. We see a trend in the PTV that the dose is slightly higher. It might not be clinically significant at this point, but the dose of the carotid could be, especially because this is a phase 1 plan and we still need to create boosts. The volume trend clearly indicates that the volume of the carotid is decreasing over time, and the cumulative dose trend indicates that we are receiving a higher dose of the carotid over the course of treatment. This gives you an idea of what the patient set up, or how the patient was being set up each day. So again, we're looking at a movie loop of the merged image and the coronal orientation. So the red area indicates the planning region, green indicates the cone CT. So the shoulder position is consistently lower than planned. And we see the extent of weight loss indicated on the lateral sides of the head and neck. Over time, that dose difference accumulation increases. So we're seeing a higher dose in the carotid gland here, as well as higher dose in the skin surface and the area of the supraclav. And you can use this information to determine whether or not when it's the right time to start a replan. We need to look at the immobilization device. We need to look at the dose differences, and the physician has information to provide an informed decision on replanning guidelines. So to summarize this type of case, adaptive dose recalculation provides information to determine the dosimetric effect of the changes in the patient over time, and the physician is provided data to make a more informed decision on when to replan. My last case is an example of a potential practice improvement. So I have 2 patients here, both being treated for esophageal cancer. Patient 1 is at 1.8 times 25 fractions. Patient 2 is 2.5 gray by 16 fractions. For patient 1, we're treating the inferior level of the esophagus at the level of the diaphragm. Patient 2, we're treating the full esophagus, but still at the level of the diaphragm. You can see the planning dose displayed on the DRR images here. We have good PTV coverage, fairly homogeneous. This plan was treated to different dose levels, but fairly homogeneous dose distribution for both plans. And what we're looking at here is the comparison of the patient setup. So for both patients, we're seeing obvious breathing changes. When you treat at the level of the diaphragm, you would expect this. And the green indicates the level of the diaphragm day to day in both cases. And we do see differences for each fraction for each patient. When we look at the dose calculated in adaptive, we see that for patient 1, we have a significant underdose at the level of the diaphragm. And patient 2, there are dose differences, but they're not nearly as significant as they were for patient 1. The PTV is underdose, and you see that again indicated here in the DBH. The dashed line is the cumulative based on chromium CT. The solid is the planning dose. And then we look at the PTV coverage for patient 2, and it looks very good. So what's happening here, and why is patient 2's plan more robust than patient 1? And this is where value also comes in. We can look at how the patients were planned. Were multiple arcs used? Were partial arcs used? How was the patient simulated? What were we using for immobilization? Do we need to implement breath hold techniques for these types of cases? But this gives you the ability to take a look and review case-to-case differences to help provide you information on how to potentially improve your practice for certain disease sites. I used an esophagus case here, but I've seen this for prostate cases. I've seen this for whole abdomen cases when rectums are full at simulation, even though people try very hard to put the patient in the most realistic set of CT data. It does happen that in certain situations the patient's just not capable of evacuating the rectum, and so what you have in simulation doesn't ever really match the treatment situation. Dose differences do occur there, especially when those anatomical changes are seen daily. So I think that a real value add is the fact that you can take a look at this and make determinations on what we need to do to make our setups more consistent, our plans more robust, that type of thing. And just to summarize what I just said, some cases are more sensitive to anatomical changes and positioning differences than others, and the tool provides information to help determine best practices for simulation, treatment planning, and then daily patient setup and image registration. So the benefits of the software, in my opinion, are that we can today assess geometric changes on portal images that are acquired in vivo during treatment, and then use the images that are required for patient setup to assess the dose differences that occur based on many factors: weight loss or gain, tumor changes, setup variation, immobilization devices, and inconsistencies between simulation and treatment. So the adaptive tool really does complement in vivo by providing dose information when measured deviations occur in a patient's course of treatment. In vivo provides the alert, we have a difference, and adaptive provides the information to tell you what that means dosimetrically to the patient. So I'm going to leave it there on the final slide for Adaptivo and open it up for questions.
Okay, thanks, Stephanie. I see that was a really nice presentation. And I see that we have one question in the queue. So if you have a question, please go ahead and add it. And the question that I see is the adaptive module. CBCT, is it MV or is it KV?
It's KV cone beam CT.
And I don't see anyone else typing in questions, but we'll leave it open for just a minute. Okay, so thank you for joining us today, and thanks for the really great presentation, Stephanie. And I wish you all a good afternoon or a good evening. Thank you very
Thank
much.
you, everyone. Thank you.